So one of the features of the Qualitex form was that it allowed,
We can, Christine, mute yourself. All right, you can go live, Amani.
Sorry, guys. Getting technical difficulties.
No worries, we're just going live now. Good morning, good afternoon, good evening, good whatever time it is, wherever you are. Welcome to Why Health with Dr. Christine Kingori, Dr. Elizabeth, Caroline Kingori. Sorry, it's because we were waiting for Christine. Dr. Caroline Kingori, CK. Okay, then I'll go to Dr. Christine Garuya and Dr. Elizabeth Washira. Thank you so much for joining us today. If you're joining us for the first time, this is the second of, I don't know how many series this will be, how many part series this will be, but this is the second conversation we are having. After we started one last week, that was a brilliant conversation. I'll get into that for a second, but the first things first I'd like to do is introduce the people that we have here. And last week I attempted to introduce them by reading some of their profiles. And in the words of Dr. Caroline Kingori, I stumbled over my words because there was so much to say. So this time I'm gonna switch it up a little bit and I'm gonna ask them to introduce themselves, just to do a little summary about who they are, what they're doing. And one of the things I want to ask you right now as you introduce yourself is what position do you hold? Because I'm going to come to that in a second. So I'm going to start with Dr. Elizabeth Washira. Please introduce yourself for us.
Thank you. My name is Dr. Elizabeth, or as my students and peers call me Dr. E. I am an assistant professor at A&M. I'm actually on campus in my office and wearing my regalia here. It's time to start school. So I teach public health. I'm the program director here. And so run the department, teaching through service learning, and then community engagement in my Kenyan community here in the Dallas area.
Dr. Elizabeth, just for the purpose of those of us who live in this side of the world, what and where is A&M?
Yes, so A&M Commerce is in Texas. Okay. Not the main A&M system. Most people know the one in College Station, but there are 12 campuses. And I'm on the one in Commerce, which is about 45-minute drive from the DFW, the Dallas-Fort Worth Metroplex.
And what does A&M stand for?
You know, I'll let you know.
Okay, I'll be Googling with you as we check that out. All right, thank you so much for introducing yourself. Dr. Elizabeth is passionate about having health equity for the marginalized and underprivileged, and we're very honored to have you.
Thank you.
Next to introduce herself is Dr. Christine Garuya. Thank you so much for joining us. You joined us just on time as we were starting, and we're so privileged to have you. Please introduce yourself for me.
Yeah, hello everyone. So my name is Dr. Christine Garuya. I'm on faculty in the Department of Emergency Medicine at the Yale School of Medicine. As an academic physician, I have a tripartite job, which means that I see patients in the emergency department or the A&D. I do teach medical students and residents, and I also do research. And I am a public health researcher, as the rest on the call. My main area of focus is on non-communicable diseases, and I shared a little bit more about that last time, and I think we'll be discussing that today as well. Thanks, guys.
All right, thank you, Dr. Christine. Before you go, tell us a little bit about the work that you're doing just with the medical association of is it Kenyans who in the US?
Yeah, sure. And I'm also the founder of the creator and co-founder of the Kenyan Doctors USA organization. That's Kedu, and it's an organization that we launched in November to connect physicians and physicians of training of Kenyan descent in the US with each other to enhance our clinical research and teaching, and also to partner with organizations back home in Kenya that are doing the same things. We've come along several of these organizations like KMA, the Kenya Medical Association, the Medical Students Association of Kenya, and others. And we look forward to continued growth. For those that are interested, please reach out to us, or you can go to our website, which we'll share in the links in the comments.
All right, thank you so much, Dr. Christine. And last but not least is our convener and visionary, a good friend of mine, Dr. Caroline Kingari. Please introduce yourself.
Hi, everyone. Similar to the other two, I'm on faculty also in the College of Health Sciences and Professions in the Department of Social and Public Health at Ohio University in Athens, Ohio. And my areas of research are in reproductive and sexual health on various health topics in that realm, but mostly HIV. And I teach courses in community health.
All right, thank you very much for introducing yourself and for doing this. And let me ask you, Dr. CK, let me start with you. Why are you convening us for these conversations? What has been your motivation for this?
So I wanted people to see a little bit more about the lives of researchers and professors, particularly in Africa. And this is mainly a Kenyan audience, but I just wanted to bring the humanity of the work we do. Someone once asked me, who are you without what you do? And I was like, hey, my identity is intertwined in the work that I do. But mostly I wanted to give a voice to people who are in this profession, who are from Africa, but also to showcase the work that we are doing to other Africans and other communities globally.
All right, thank you so much for doing that. And we've had such good feedback from the conversation we had last week. We had to have a second one. When it's good, do it twice, right? That's what they say. Okay, that's what I say.
I like that motto.
Isn't it? So last week we had a really good conversation because we got to hear a little bit of your stories. We got to hear how you got to where you are. How you got to where you are. Moving into the US, studying, doing the research work, getting to actually doing work, and what you do back at home. We got to do a little bit of the different spaces that you've gotten in. If you are not there, please look for the live. We'll post a link. The recording for that live, we'll post a link. It was a really inspiring conversation. I left inspired. I almost wanted to become a doctor after the conversation. But before that, I knew I'd never. No, I don't do blood very well, so I didn't want to become a doctor. So I want to go straight into the conversation, or a question rather, that we had from the conversation last week, and I'm going to read out because it's both a question and a comment. So I'm going to read it out as it is verbatim. This person says, I think it was a lady. She says, I have observed this one particular issue. Oh, let me start with her second comment. She starts with, also, I was encouraged by your lecture yesterday. I think that was for CK. Was that, yeah? I haven't finished just yet because
it was Elizabeth. It was Elizabeth.
Oh, it was Elizabeth. Oh, wow, it was Elizabeth. All right. So she said, I haven't finished it just yet because I had to present a lab-wide research update this morning after a week of moving, but I'll do so this afternoon. Why I wanted to read it is because she says, it makes a really big difference to see three faces that look and sound like me who are making strides in STEM spaces. Thank you to all the three of you. And so I just wanted to start with that so that you're making a difference and people are inspired to see this. So the person asks this question. I've observed this one particular issue that has come up over and over again, especially during the pandemic. Lack of trust of healthcare providers by the people because they feel that enough is not being done at the ground level, which sometimes leads to non-compliance. And non-compliance, she means masking, physical distancing. And she says, these are great, but they don't go far. Staying at home has proven more harmful than helpful. And data bears that there's increased drug use, alcohol dependence, mental health, suicide, homicides, child abuse, etc. And that's all over the world. So our question is, why is integrative medicine defined by healing-oriented medicine that takes into account the whole person, including aspects of lifestyle, not part of the health model? The emphasis here is on lifestyle modification, more things people can do to enhance their immune system. Exercising, eating nutrient-rich foods, avoiding processed foods, water intake, sleep, and spiritual nourishment as well. And she says the reason she asked this is, I think if more emphasis, research, tax dollars are placed here, health outcomes will be far more superior, not only in COVID, but other communicable and non-communicable diseases. So she wants to know, why is it not a holistic approach? Let me start with you, Dr. Christine.
Sure. So it's a really insightful question. Yeah, and it's a challenging one because the issues the individual is asking about are issues that we as healthcare providers and public health professionals, even government officials, I think, have really struggled with. So this issue of lack of trust, and I think she says it sort of stems from not having all the answers or feeling like all the answers are not being presented to us. And I will just say it's frustrating for all of us because healthcare providers have felt a lot of the same way. Public health professionals, if you look at the CDC, have felt the same way. We don't know enough about this virus to be able to have all the answers at this time. And that's changed over time. We've gotten to know more and more. We started out not knowing how it was spread, right? And so now we have a pretty good handle on that. We started not knowing what kind of mask would be helpful, or would masks even be helpful. And now we know a bit more about that. We started out not knowing what treatments would work and which might work. And now we know much more about that as well. And now we're months, if not a month away from possibly launching a vaccine, right? So the point is that it's a novel virus, novel meaning new, novel meaning we didn't know anything about it prior to it having occurred in our communities. And so it really has to take patience from everybody. Certainly healthcare providers have struggled, let me say, with going to work and putting themselves at risk and their family members at risk, but they still do it. It's the same way when I gave that slogan, we go to work for you, so you stay at home for us. We hope that we as a community can band together and do our own respective roles of also staying home to protect yourself and protect those around you. The second point is this idea of comprehensive care and why is it, she said, quote, not been employed. That's actually not entirely true. So I will say folks like myself who are trained in what's called allopathic medicine, which is sort of the conventional form of medicine, we absolutely are taught about those things with probably less emphasis on them, but we're still given the opportunity to approach medicine that way, including with regards to health education and so on. There's a whole schooling of medicine called osteopathic medicine that actually focuses on things like acupuncture and chiropractic medicine and all these other things that are sort of quote unquote non-traditional. And if somebody has the desire to pursue that, they can. And the last part I just wanted to say about that was mental health providers, right? So I think she said that people are staying home, but we're having more drug abuse and mental health. And I think that's a completely different conversation. We could talk about that for much longer. I don't know if the ladies, we want to speak on that a little bit more today, because she mentioned it, is mental health is a real issue with the COVID. But this is an important point that mental health is a problem, and don't ignore it. So if you need help, if you are stressed, experiencing depressive symptoms, suicidal ideation, get help. Mental health providers are there. They are working in functional ways via virtual aspects, Zoom. I know many of them in Kenya. I know many of them here. There are opportunities to seek care for that. So, it's not, I don't want to say it's an explanation, but it's not an excuse. So, like I said, access to those diverse aspects of care are possible. This is frustrating, but it's frustrating for everybody. And, mental health, and seek care if that's what people are needing help with.
All right, thank you for that. Anyone else would like to take it?
Yeah, to echo what Dr. Ngaruya said, again, because people don't know so much about this health issue, we're sort of walking through the darkness, and saying, oh, I guess the masks have worked before with other communicable diseases like the flu and the 1918 flu outbreak. We can maybe try that. And so it's in trying to figure this out that there's a lot of confusion, I will say that. But also, I think what she's alluding to is the fact that there has been a lot of top-down sort of development of strategies as opposed to bottom-up strategies, where it's so important to engage the community first. But with this pandemic, things had to be done so fast that decisions had to be made top-down. And so with that confusion, I think we're getting to a place where now we're trying to balance it out and, talk to our communities and emphasize the importance of using these strategies, whether it's maintaining distance or washing your hands or using masks. I think it's just a matter of people having buy-in to that. When you're thinking about that alternative and complementary medicine, it's so critical. And it's a very important area in the healthcare system here in the United States. And Dr. Ngaruya gave that osteopathic medicine as a route that other doctors take to practice medicine. It hasn't received a lot of popularity because we know modern medicine is what is known across the world. But meditation, again, acupuncture, those are things that people can use, especially when you're dealing with the mental health impact of COVID. So for example, like I do a lot of meditation because sometimes you feel stuck, working from home, etc. But yes, there's definitely heightened need to look at all those other factors such as gender-based violence, drug use, etc., which have become worsened by this pandemic.
Yeah, and I'd like to, I'd like to piggyback on what they have both said, and the idea of that comprehensive inclusion of all aspects of health, right? We talked last time about health not just being the absence of disease. There's so many other social determinants, and Dr. Christine mentioned about why it's important to focus on poverty, to understand why certain countries have this double burden of disease. And we have seen with COVID that there are some populations that are hard hit. So I think even as we approach the novel, new COVID-19, we are fine-tuning things, but we're also using data, evidence from the past to critically assume that there are some things that are similar to COVID, to the flu in terms of transmission and all that, and that there are people that will be a little bit hard hit with COVID, the same way they're hard hit with HIV. So I think it's also it's challenging all of us. And I love what Dr. Christine and Dr. Caroline said, to approach it comprehensively, that mental health is a part of the treatment plan, that acupuncture should be something that is included there, because if you go to a certain country, the norms are different. Christine mentioned this last week about how what we know in terms of a treatment is based on maybe the Western types of research, but we have what works in East Africa, in West Africa. So when we approach it comprehensively, we're able to now tackle not only wearing masks, but within that understanding of the community, as Dr. Caroline said, what is important to them and what else are they struggling with? So that idea of partnership with other disciplines, but also the community and the patient is important no matter what we're tackling.
Right. Thank you for that. In fact, you touched on something I wanted to discuss, but I'll segue for a minute. One of the things that I promised guys last week is that we'll talk about your work and the work that you're doing. So allow me to just segue into that for a bit. So the question I want to ask you guys is about the research work that you've done, the places you've been engaged with when it comes to just developing thought and developing thought leadership. And maybe the question I want to ask is pretty simple. What has been the most interesting research that you've done, and what has been its findings? What are some top line findings that you've gotten? I'll start with you, Dr. Oshira.
Honey, you always start with me. Listen, I want to be in the middle sometimes, but it's okay. It's okay. I'll be first. So my research, as you introduced me last week, is on health equity. It's really, I love social justice. I'm an advocate in the community. So my research specifically with marginalized populations is trying to understand their plight, trying to understand how their marginalization tied to their identity manifests in their everyday. So my focus is on the homeless population because they intersect all populations, whether race, gender, sexual orientation, background. So they're a very diverse group of individuals. And guided by the theory of intersectionality, where we have to focus on the different identities a person has to understand the unique experiences with prejudice, for example. So the findings have been that how we live out our everyday actually is a testament of the vulnerabilities that we experience. So for example, the homeless, the finding was that the most vulnerable individual experiencing homelessness is the one that is always in motion. They're always moving from point to point. They're in hiding because they have been so pushed out to the margins to where they're hiding from the domiciled population, whether it is police due to criminalization, because homelessness is illegal, quote unquote, in terms of you're not supposed to be there just sleeping on a park. You're not socialized norms. And then that person that you never see. In the service setting, we put out outreach programs, we put out services that we are doing. And some individuals do come, but the most vulnerable person is that person that, because of what they have been through, they don't trust the everyday society. They've been marginalized, they've been stigmatized, they've been hurt. So they don't show up to these programs. So the call to action is to go to them. Don't wait for them to come into the hospital setting. Go into their communities, build trust. Trust is also a solution to some of their problems, because they won't tell you everything if they don't trust you. So part of the time service providers need to invest in is facilitating trust to understand the comprehensive individual in terms of their needs, in terms of healthcare, but also the experiences, so that way services can be adapted.
No, what's interesting is that you're saying that within the homeless community, there is a marginalized person outside of that already marginalized homeless community, and they're saying that's the most vulnerable. We'll come back to that, but that's very interesting to pick out. Dr. Kingori, tell me about your research.
So you alluded to some of that research last time when you talked about HIV stigma. And I've looked at HIV stigma in Botswana and in Kenya. And I just wanted to say that when you think about HIV stigma, we are looking at internal and external stigma. And what is critical about stigma is how it can impact an individual's, their ability to interact with others, ability to go to work. It impacts their mental health in terms of depression and anxiety. And the fact that if they can't go to work, if they can't socialize, that can also affect other people within their family setting. And so it also impacts the ability to take their medication, the ability to talk to their sexual partners and disclose their status, or to even receive social support. And so for us to be able to address this stigma, we have to ensure, again, the first line is to make sure that people have adequate knowledge of how HIV is transmitted. There are people who still think HIV is transmitted by mosquitoes, that HIV is transmitted by people sharing clothing or food or the same utensils. And it's like, what? It's important that we ensure that everybody understands how HIV is transmitted, but we also have to make sure that those who are HIV positive have a place for support and encourage them to attend social support groups. But also it's important to make sure that these strategies are culturally competent or culturally acceptable in each community. So what we do in Nairobi may not work in Nyeri, may not work in Mombasa, may not work in Uganda. And so it has to be relevant. But the one I wanted to highlight was intimate partner violence. When you think about that question that was asked about COVID and the negative impact it's had on communities and families, we analyzed data with a colleague of mine, Peter Memaya from Maryland University, who's doing great work in Kenya. And we were looking at neonatal, infant, and child mortality among women who are exposed to intimate partner violence. And we looked at what we call the demographic and health surveys. And this is just a series of nationally representative household studies. And we looked at 5 countries: Burundi, Kenya, Rwanda, Tanzania, and Uganda. And we found that it's important to realize that a mother plays a really critical role in the well-being of a child. And so the well-being of a mother is important. And if it's not handled or taken care of, that will have an impact on the child. And that can influence these deaths that we're talking about. So the findings from this study found that children born to women who experienced intimate partner violence, or what we know as gender-based violence, were significantly more likely to die as newborns, and they were more likely to die by the age of 5. And the factors that were associated with that included being young, 20 to 29 years old, not attending antenatal care, not being aware of the birth weight of their babies, living in the rural areas, not having access to mass media. And so it's important that these strategies that we have in the country in terms of interventions, that they take into account the importance of addressing intimate partner violence and ensuring that women have equal opportunities for access to care, but also that they're protected at home. And then the final one was sexual violence. And we did this in Botswana, where we were looking at sexual violence among orphaned and vulnerable children. And so we couldn't talk to the children, we talked to their service providers, and we were looking at their experiences and perceptions. And, you know, again, sexual violence is common across different countries, across different communities. It happens a lot in schools, happens a lot in homes, in rural regions. It's associated with depression, sexually transmitted infection, impairment of education. And so some of the risk factors for this sexual violence among these children was, you know, being female, coming from a home that's dysfunctional, also not being able to take care of, not coming from a home that has adequate income. And so, and then the other really critical part was that culture of silence around sexuality, and also the social expectation that children should only be seen and not heard. And so sometimes even when a child says that uncle so and so, or, you know, my neighbor is doing bad things to me, they're not believed, and, you know, then they decide to keep quiet. So the protective factors for that is to ensure that there's adequate adult supervision. They talked about recommendations on how we can advertise on or engage the community. So again, this has to be centralized within the cultural context. We have to make sure that we don't rely so much on those external organizations, but bring the community together so that the community can decide what's best in addressing these issues, because they're pervasive and they're continuous. And if a child is abused, if abuse is happening at that stage of childhood, you can imagine what happens to such a child when they become an adult.
I am so depressed. No,
Don't be.
like I really am. No, and it's, I'm not even saying it in a bad way, but it's just that I think sometimes, you know, when you're not involved in such work, and that's both what you're doing and what Dr. Washira is doing with the homeless communities. I mean, every time you hear this new information, or this information that's not part of my daily consumption, it really is heavy. And let me say thank you guys for the work that you do, work that many of us would be unable to do. Dr. CK, I have one question for you before I move to Dr. Ngaruya. You talked about internal and external stigma. Would you differentiate those for me? You're muted, Dr. CK.
Internal stigma, when you think about people who are HIV positive, it's how they perceive themselves, right? And how they perceive themselves based on what they think the other person thinks of them. And that's usually a very challenging stigma to address, because it's the thoughts that they tell themselves. And then external stigma is, you know, what the other person is thinking of you and how they express this stigma through discrimination. They decide they're not going to hang out with you, they won't eat with you. And so external stigma, you know, you can have people receive, provide them with the knowledge, HIV knowledge, tell them that don't be afraid of people who are HIV positive, but the work is more on that internalized stigma and trying to convince this individual that they are worthy, that they matter, that they are enough, and things of that nature.
Wow, okay, thank you. Dr. Ngaruya, please tell me your work involves balloons of different colors. There's a rainbow and a unicorn at the end of the story, please.
Yeah, Amani, you bring up a good point that, you know, unfortunately in research, we're looking for the problems that hopefully we can develop solutions. But no, you brought up a great point. So I will start on a lighter note. So I was going to make a point because you asked about the impact of our work, but also what we do. And that was for some of the mentees who may be watching, specifically way back 15 years ago when I didn't have access to funds to come home and do work there, which I wanted to always do. I worked with refugees in Nebraska, of all places. That's in the state right smack in the middle of the US, Ushago, that nobody knows about, which is coincidentally the highest, the state with the highest refugee resettlement per capita. And so developed an intervention there that has now targeted like 5,000 refugees, Sudanese to, Cambodian to everything in between. And that's a health education and language to care program. And that was just a point on impact regarding to say to mentees that are watching, it's okay to start in your sphere of influence and branch out from there, which my story continued to finally get to do some work back home in Kenya as of about 10 years ago, and really kind of ramping up over the last 7 years. And again, sort of that story is a story of having some grit and cold calling and cold emailing people, like I said last time. So I started out with Kemri Wellcome Trust, doing barriers and access to hypertension care in Kilifi. I moved to APHRC, which I really laud for all the amazing work they do in Kenya African Population Health Research Center, which is based in Nairobi. And that was looking at equity and access to mobile health, texting intervention for non-communicable diseases, getting people care there. And then I mentioned, I think last time, working with Ministry of Health to do the first ever national study on NCDs in Kenya, which was really impactful in terms of, like I said, our outcomes and really just showing NCDs, non-communicable disease are a problem in Kenya. For me, sort of my heart place got to where I wanted to actually be finally occurred about 1 year ago when we conducted this 900 person study at KNH at Kenyatta in the emergency department, looking at patients and their NCDs. So we know in the US and the UK, A&D patients are have the worst of the worst health status. These are the people who really don't access care. These are the people who, I remember when I was like 10 years ago, I came to KNH and rotated as a med student and saw this Maasai woman who came with her whole clan. And, for this quote unquote finger pain, that was a diabetic gangrenous finger. Basically the finger is gone, right? So these are the people who are coming with the worst of the worst health status. We finally did a study on NCDs, probably the first ever in Africa of its size. And we found that for sure, for every single outcome of non-communicable hypertension, cancer, tobacco, alcohol, they're all worse, if not double, in the emergency department in A&D. And nobody's addressing that, right? So now the happy ending to that, Amani, is that I'm working on interventions. All of my projects the next 2-3 years are going to be interventions targeting those exact risk factors. So I actually have 2 programs that will hopefully be launching as of next year using text-based interventions, enrolling patients in A&D for tobacco cessation, for alcohol reduction, and some other things. So watch this.
All right, good stuff. Thank you. Thank you so much for being so kind to my little weak heart, Dr. Ngaruya. I think the question I want to ask is both for you, Dr. Ngaruya, but for the rest of you as well, because a lot of what I hear, there's a lot of behavioral undertones, maybe not even undertones, like it's out here, it's about behavior in some sense, in how you treat and deal with the community. So, and I know behavior is hard to shift, especially when it comes to healthcare. I don't know why. I just know it's hard to shift behavior when it comes to healthcare. And so what are some of the things that you're doing that can influence the shift of human behavior when it comes to your different areas of research? Let's start with you, Dr. Ngaruya.
Sure, that's a really great question. And actually, I think it gets a little bit back to the point of the other individual saying, why aren't we putting more research into understanding what other, non-conventional things are being used? And I wanted to reassure her and answer your point in saying that actually that is being very much prioritized in research in public health these days. If you're not using some form of a participatory approach, and I'll explain that, in your research with regards to behavior change, then you're sort of being frowned upon. And when I say participatory approach, it means truly engaging the community that you're studying, both in active and passive ways. I'll give you an example of Kemri Wellcome Trust, who's very well known in Kenya. They actually have a whole unit specifically involved with community engagement. And this team literally just goes out to the community, tells them about the study, talks to the leaders, elders, and if the elders say no, that's the end of that study. If the elders also guide them on how to recruit, ideas on the nature of the project, etc. And so for me, again, for all of my work, it really involves getting the people you're targeting on a team, almost as part of your research team in a way to guide some of the interventions that you're designing. For you, you may think this word in this text is going to, they tell you, no, actually that word is going to turn me off. I don't even understand what you're saying. oh, this topic you're addressing is actually a little too sensitive for this community, it won't work, but maybe for the population that Caroline, Dr. Kimori works with, there maybe it will work, right? So you need to be a little bit more, kind of hand-holding, more, kind of carry things with gentle hands, and you should be able to get to the answer of that. But you're right, it's not easy, but that certainly community-based participatory research is key.
All right, thank you. Dr. Ashira, you're definitely one of those people that's right in the heart of community engagement. And, especially when you think about the homeless people, you'd imagine that they already are aware of their need for healthcare. And so you would imagine that, they'd be the first to take advantage of anyone who is willing to go down to their space or call them out into a place where they can get healthcare services. What's been your experience in community engagement? What are some of the things you can give us tips for that shift of human behavior? You're muted.
Yes,
okay.
That's a great question. And I think we've been talking about this since day one. I think last time I said, it's very important to walk in to take off your shoes and walk in the shoes of that community. Because if we come up with the intervention, as Dr. Christine said, oh, here, this is what you need. One, it won't work. Research has shown if the community is not involved or the person you're wanting to reach out to does not have buy-in, then whatever intervention, it could be the best thing in town, but it's not going to work. So with the homeless community, the transient community, understanding their lived experience. So for example, if I'm a service provider and I have this open hours at 11 to 1, and I don't ask the community, is this a good time? Well, 11 to 1 is when the soup kitchens are open. That is when they are going to eat. I could be offering them the best thing, but the first immediate need in that moment is they're hungry, right? They don't want education. We first feed them and then we bring in the education. So it's that being very innovative. And public health, we are the most innovative people. As I feed you, hey, let's talk about this as well. And before you even start that, you have engaged gatekeepers. So what is the most important need to you, and what are some ways we can tackle that? So the first thing is engaging, is communicating, it's opening up the round table to where it's not me as a researcher, the expert, is we're experts together. I may have knowledge on the best way to write or where to get these resources, but you are the expert on your everyday. And that goes for whether we are working with the Maasai population or that HIV individual in Kenya. We have to understand. So for me, working with this population humbled me, first of all, because it called out biases that I didn't know I had. For example, think about when you walk across somebody that is homeless, they look questionable, you hold your purse a little tighter. You don't know if that person is going to steal that purse, but that holding your purse a little tighter, you may not notice it, but they do. And because they do, it says, oh, already that interaction is questionable. So I had to call out biases and say, what is things that I think about the homeless that are negative, and where did that information come from? Because I don't have a friend at that point that had been experiencing homelessness. So my knowledge had to be questioned, and I had to really work to put down those things and now rewrite the narrative of who these individuals are. And my research and all the research about this population is that they're very resilient. The fact that they survive day to day, they're the most hardworking people because they have gone to find food. They have made that $1 count. I'm struggling with a budget of maybe 200, and they have maximized the resources that they have. So building empathy, and as we have all said, getting to understand and level the playing field, not come in as I know it all, but come in humble and say, hey, teach me, and let us combine and work together. Community participatory research, let us work together. where we are both actively involved to tackle this problem based on what, yes, evidence says, but adapting it to your community.
Oh, wow. Thank you. Thank you for sharing that, because you got me asking about my own biases as well. And I nodded when you talked about, holding your purse a little closer, not because I do hold mine, but because I understood, what you meant with the analogy. And I did a podcast not too long ago with a man who had been homeless as a result of alcoholism. And he talked about it, how, when he walks up to you, for a lady, you sort of clutch whatever you have a little closer. For a guy, you're spoiling for a fight, even before he said what, you're threatened. And so I really identify with what you said. Dr. Kingori, your work is really around behavior as well. Your work is really around, getting people to shift behavior. In a nutshell, because we're really running out of time. In a nutshell, what are some of those things that you've picked up that can be useful?
So first of all, behavior is very difficult to change. And it's the one thing that we need to do to make sure that people live optimal lives. And what influences behavior are those perceptions that people have, those beliefs and attitudes that they hold towards certain behaviors. So if you're trying to change smoking in an individual, and this individual lives in a household where their grandmother, who's 99 years old, is still smoking, how are you going to tell them smoking is bad for their health, right? And so some of those, the attitudes, their beliefs, and also the people around them, including the resources that they have in place to help them manage their behaviors, is what really has an impact on the extent to which they'll change their behavior. I'll give an example of exercising. Okay, so we are always told to exercise. We're always told to eat healthy. But do we know what we need to eat, right? Can we afford what we need to eat? If I tell you to exercise, can you afford to go to a gym? If I say you can exercise outside, is it safe for you to exercise outside, right? Is the local, what am I gonna cancel, making sure that your outside is clean, that it is well lit? And so there's so many factors that play a role in determining the extent to which one person is going to be able to change their behavior. So the burden of change is not on me. The burden of change is on a lot of other factors that include me, include the people who are in my life, include the resources in my community, and also the policies that we have set.
Oh, wow, thank you for that. I'm going to invite questions. So if you have any questions that you'd like to ask, please feel free to type them on the live chat and we'll get to see them. But I'd like to move a little bit more into your personal lives, just because I want to know you a little better. And yes, one of the things that I'd like to know is just maybe in a quick sentence, how has COVID affected your life? Let's start with you, CK.
I'm telling you, how much time do we have? No.
Exactly 3 hours, isn't it? Just
so it has definitely been a shift in how we think, in how we relate with others. Me being an extrovert, that's someone who likes saying around people. This has been very challenging because it feels like I'm in a prison somewhere, and I've had to be creative in how I spend time with people. And so I've had to use Zoom and Teams to set up ways to talk with people, also hanging out with only 1 or 2 people. But what has been amazing about COVID, it has brought out some creative juices in me. And so I was able to launch my podcast, Public Health Musings with Dr. Kingori. And I'm so excited about this new thing, because my job is everything. I do it every day. I've mastered it. But there's always something with a podcast. And then doing this with you guys also. So every time my brain is moving at 100, because I'm home so much. So I need to find ways to entertain myself outside of my regular job.
Good stuff. Dr. Ngaria.
Yeah, so man, I mean, just to be frank and honest for the viewers as well, I can just tell you that when COVID hit the US in early March, it was terrifying, right? So, and for me, it was a mix of, fear over my friends and family, but it was also a fear over my own life as a frontline healthcare provider in the emergency room, over my colleagues who I know and love very dearly. And, what was going to happen in healthcare? Were we going to all be deployed? What was going to happen? And so it was a rough, I think, few weeks. And then sort of like Caroline, Dr. Kumori, I had this sort of realization that I had to function and be well. And we talked about mental health as well. And so it's been really important for me to compartmentalize. And I think that's what Dr. Kumori was saying. Compartmentalize meaning, there are times for COVID, and then there are times for absolutely no COVID. And, for me, I love my job. I don't actually call it work per se. I did a lot of actually research and writing and publishing and a lot of kinds of things with that. But it was also finding time, like Dr. Ngori said, just with friends and on virtual, hangouts, doing game nights on Zoom and reconnecting with people. I've had conversations with people for an hour and I don't remember the last time that happened. So right, but just that compartmentalization has been really key. So, yeah.
All right, Dr. Ashira. COVID hasn't changed your life, right? Yes, just the usual bubbly self, right?
So, yes, I'm always bubbly. So for me, I'm an introvert. And the first month I was like, this is what introverts have been training for, staying at home with my candles, with my blanket, and just me, myself, and I. But I'm an ambivert. I like the energy that I get from extroverts. I love being in a space where just that vibe is really good with my friends. So I was good the first 3 weeks. And then after that, I said, okay, I need people because I cannot self-generate energy by myself. So I had to get innovative, as the ladies have said, and compartmentalize, because now as the public health person, everybody's hearing, they finally, for some reason, oh, you do public health. Wow, it's important. So I had a lot of questions coming my way, and same with Dr. Kingori, launched a Talks with E around that time on everything. It's not for, I'm eclectic, so it's on everything. And at that time, one of the conversations was on racism, right? With the racial injustices and George Floyd and all that. So for me, I channeled my energy there, and that helped me be able to even cope. And mental wellness is so important, and we forget that. We really, really do. And for everybody here and viewers, we have to be whole, we have to focus on all aspects. And for first responders, their mental wellness at this point became challenged because they're the givers, they're the providers, the protectors. So having to focus and remind, my mom is a nurse, saying, hey, take care of self, take care of self, take care of self. And they're the ones taking care of everybody else. So it really opened up my mind to innovative ways of connecting with people and using the platforms, few as they may, that I have, to not only educate, but inspire and bring another idea. Alluding to the question that lady said, when somebody that looks like me says something that hits in my heart, I take it a little bit better. So using the spaces that we have and facilitating webinars on mental wellness. I'm not an expert, but I can sure play a YouTube video where somebody did a really good job and then facilitate a talk. What does that mean to you? So that's what I've been doing, talking a lot via Talks with E, and that's where I am.
All right, thank you for that. And that allows me to go into the next question I want to ask you guys. So you're all like really serious and important people. Really serious and important people. And I'm wondering, do you always take yourself so seriously? Christine, Dr. Ngaria, relax. I'm not yet there. So, but do you always take yourself so seriously? Do you have fun? Do you have time for fun? Even pre-COVID, and it's both what you said about taking care of yourself as well. How do you do that?
Me?
Yeah, you can take that.
Sure. Okay. Actually,
I was afraid of my next question.
I sure was. I was nervous where this was going. No, just kidding. Thanks so much. You're doing a great job. No, actually, one of the hardest hits for me was that I really love to travel. I really, really love to travel. That's probably my number one hobby. I've been to 32 countries. I do a lot of solo travel. I just pick up and I say, this is where I'm going next. I love, love, love travel. And I had so many trips planned for this year. And so, COVID took that away from me too, so it was a hard hit. But honestly, if and when life opens back up, I encourage especially women to get out and do a little bit of traveling on their own and explore. And then I am an extrovert as well. So I love hanging out with friends. And yeah, I got a dog. Also, I'm one of the people that's subject to the COVID puppy. So that's my newest roommate. And yeah, no, absolutely. You have to have balance in life. So many people, mentors, and everyone will tell you, you really have to have a good personal life to do well in your professional. There's just, you cannot have one without the other. So absolutely key. Thanks.
Okay, thanks for that. Dr. Kingori?
Yes, so extrovert, we are always trying to find something exciting. I had to learn to sit still, but what I do for fun, just like Dr. Ngaruya, traveling. I am close to the number of countries she's been to, so I'm really trying to get up there with traveling. And the good thing about traveling is you learn about other people. It really humbles you, it makes you really small when you see how other people live their lives, but you also get to interact with them. But what I did is take up meditation, breathing meditation in the mornings when I wake up, because sometimes with our brains, when you wake up in the morning, what you didn't think about at night comes rushing in the morning. Did you do this? You need to do this. If you check your email, that's it. Your brain just goes nuts. And so I took up breathing meditation, and then I started doing some stretching exercises in the morning as well, and just to get my blood flowing. And I do exercises in the evening as well, including walking. So there are days I don't feel like exercising, but I'm like, let me go outside, especially now it's summertime, it's nice. The other thing, I'm cooking a lot. I do enjoy cooking. So that has been exciting. I'm reading books. I like reading books from African authors. And so I've had a few books that I've read and have finished. And so that's what I've been doing. And of course, the podcast as well, that has been fun.
All right, thank you for sharing that. So on our next episode, we'll be doing a cooking tutorial with Dr. Kingori, and you'll be showing us how to make quick meals while you meditate. All right, okay. Dr. Washira.
So let me represent the introverts all across the board. Introverts need people to travel with, because I am not about to say the first hello to a stranger. So I travel with people. So any of y'all, please invite me, and I'll be the one in the backdrop after you say hello. For me, what have I been doing? I've been reading a lot. I love to read. So I have a book club called Becoming Engaged that we read books and talk about different things as women. And one of the books, actually, the books we're reading right now is called Relational Intelligence, and the idea of emotional intelligence and, IQ and all that. And one of the things it says that if you need to know what you need. And so for me, I am a workaholic, because when I get in that space, I can stay in that space. So I've been very intentional about finding people not in the public health or the academia world to push me out of that, to where they're all about fun. I'm like, okay, stop it. But they force me to step out of my shell in terms of trying new things, because I am the safe, calculated. Even as a little kid, my brother was on the trees. If my mom left me on the sofa, 5 hours later, she's gonna find me on that sofa, because my situation is just too scary. So I need people that are extroverts and risk takers, because I just will not take a risk. So I've been intentional about doing that lately. And then I love so two-stepping, country music, cooking with country music, and sewing. I do a little bit of sewing and DIY, so I've been doing a lot of that.
All right, so I'm not seeing any questions coming through yet, so I have a last question, and this will be how we close this webinar today. And I'm really asking because someone said it's very cool to see 3 people like me who are doing what you're doing. Now, question: what have you had to sacrifice to get to get to where you are now? You know, what are some of the things you've had to sacrifice? And I'm hoping I'll hear what relationships you've had to sacrifice, if there are any, or which ones have helped you build up. But let me hear what you've had to sacrifice. I'll start with you, Dr. Kingori, as I give someone time to think through her answer.
I think, you know, with what we started saying last week, you know, I gave up living in Kenya, right? I gave up seeing my family every day, interacting with them. And then when I moved here and went to Maryland, I had to give that up to go do my doctorate in Indiana. And so what I've had to give up is family sometimes, relationships sometimes, time to myself, because I'm trying to do homework, or I'm trying to attend conferences, or I'm trying to write papers. But I think in the last few months with COVID, it has helped me rethink and reshape my life. And how I want and what I want to do moving forward. I want to leave a resounding legacy. So and also to be alive to do that.
All right. So before you go, you're going to answer a question by Yvonne Kuptong. What's your relationship status? Are you single? Are you dating? Are you waiting? Are you in a relationship with your...
I plead the fifth.
With a dog? Okay, you plead the fifth.
I plead the fifth on that.
I'll take it. Okay. Dr. Oshira. Dr. Oshira, what are your...
Yes.
What have you sacrificed? What have you sacrificed?
So, because when you're going to the library, and that is when that party after party after party is happening, you're not there. So you're at the library while you see everybody hashtag turn up, hashtag, you know, this. My hashtag is hashtag build a legacy. So time with not only family. For me, I'm fortunate my family is in Texas, so I didn't have to say goodbye to my immediate family. But during some busy times, I do have to say no to family time, or being able to get up and travel, go somewhere. So that, and then, you know, let me just put this out there, because you're the representative of the species that betrayed Jesus. So you know and tell your men. When an empowered woman walks into the room, it can be very intimidating. Yes, yeah, I know it. I said it in Mesema. It can be intimidating. So when you're used to being the lecturer, the speaker, the person with all the answers, and somebody wants to come and ask for your number, the barriers that they, for some reason, foresee to do that are so many that they say, you know what, Shauri. And because us, we over here plugged into work, 2 a.m., library visits, we may not notice those people. So sacrificing relationships too as well, the time, you know, for that, or the sacrifice of sometimes having to step out of your shell, to, as Dr. Christine said, to not be the doctor, to not be the spokesperson for these, or to not be the one with answers, to just be. It's difficult. It's difficult, and it's a learning process. And many of you are out there. Don't be challenged by an empowered woman. Become empowered yourself, boy child, and maybe ask Amani to shoot your shot for you and step aside. Nimesema, I'm done.
Hey, shots fired. My goodness. Wow. Hashtag turn up, turn out and ask. I don't even know how to respond to this. I think this webinar is over. I'm done. You don't even have to answer this question, Dr. Ngaria. It's over. It's so, Dr. Shira, can we assume you're single?
Yes, because I am not married.
Okay.
Yes, so assume I am single because I'm not married.
All right, she's available for comment. Now you know. All right, good stuff. Dr. Garia.
That's funny. Yeah, no, this is a good question, guys. I mean, it's not uncommon to get this question. I'm going to be as frank as I can for the young women who are watching, which is that, so in some, I am also single / dating. And my example of this I give is, I remember after my first year of medical school, getting done with medical that year, doing really well, but getting to summer and not having anyone to call or text, and being like, wow, I actually have no friends. And it was a wake up call for me that was like, as an extrovert, especially like Dr. Lori said, this was not going to be my reality. And I've lived my life accordingly and have prioritized friends just as much as I prioritize my work, even though sometimes work suffers a little bit. With that said, like Dr. Washira said, yes, we do miss weekends. Yes, I do miss some holidays. Yes, I don't go to all the parties that everyone else is going to because I have commitments that I'm really passionate about. But again, my life is full. I have no regrets. And again, I say I'm single and dating very proudly because my life is full, and because as someone who's a Christian, I identify as being Christian, I also believe strongly that if God has a plan for your life, don't shirk that with somebody, and the other part of that is don't shirk it with somebody who's not equally yoked with you. And equally yoked, I mean not just the Christian way. I mean who's not on the same goal, doesn't have goals that are getting to the plan that, or the plan that God wants you to fulfill in this world. I totally believe my mission, my gift, my whatever is around clinical practice and public health. And that's what I need to be living in fully. And if somebody's not quite on that path, then we're probably not meant to be together. And that is sad with having had some very healthy relationships, but who just weren't the right person. So yeah, you can have it all, ladies, just, at the right time. So yeah.
Very true. Hashtag single but not married.
Hashtag single but not married. Hashtag next webinar is about how to date a doctor. So
Maybe.
Our time is up, and it's crazy how this time ends so fast. And when you're really having fun, and to be honest, I'm having a lot of fun doing these conversations with you. Thank you so much for being open. Thank you for being so candid. And thank you for sharing your work with us as well. Thank you for the work that you do. For those of us that are on this other side, as your patients, as the community that you engage in, I'd like to add one more thing that we want to do for you. We want to be your cheerleaders as well, and say that you're awesome. You're awesome. If I get the opportunity to introduce you again, this is what I'll say: you're half woman, half awesome, because that's exactly what you are. And so thank you so much for the work that you're doing. I want to do this conversation.
I wanted to say one thing. Today I was meditating, and the person who was leading, the instructor who was leading the meditation, you do all the breathing exercises, etc. And he said the one last thing he wants us to do is to tell ourselves, I am enough. And that's what I want to say to everyone as we go out. Tell yourself every single day, I am enough. And I had to tell myself, I didn't realize, because we're always going. And it really hit home when I said I am enough, even as I pursue all these dreams and all the goals and building a legacy, etc. I want to encourage everyone to say that I am enough.
All right. I don't think there's anything to add on to that. You're enough. Thank you. God bless you. I hope to see you again. I hope we can have more. No, they're saying no, Dr. Washira. No, we're going to see you again. We're going to have more of these conversations. And I'll have this.
No, I was saying yes.
I'll have this whole troop of guys I'll be rallying between now and the next webinar, the next live. And they'll be asking all the right questions about how to date a doctor. I'm joking. But God bless you. Keep your heads up. Remember that we're cheerleading for you. And for you who's been listening and watching, I hope you've enjoyed yourself. I hope you found some nuggets that you can take home with you that are inspiring, that are about the work that these ladies are doing, that you can plug into. And what I'm going to ask, ladies, if we can add resources onto links here that people can figure out how to plug into the work that you're doing, let's do that. God bless you. Have a great week. And thank you so much for doing this.
I think I wanted Elizabeth to Dr. Washira to talk about how to get the links. Could you talk about where to get these links on Talks with E?
Yes. So the links for Talks with E, and I will post everything that the doctor said. I will post on that live chat. But we are on Facebook. We are on Instagram, Talks with E, Public Health Musings with Dr. K, and on LinkedIn as well. Dr. Christine is on LinkedIn, and she has posted the Kedusa.org. So if you tag into one of those, you will see all those Talks with E, LinkedIn, Kedusa, and Public Health Musings, and we'll be sure to, in the live chat, drop those as well shortly.
Okay.
Thank you, everyone, for watching.
Thank you
Thank
so
you,
much.
For
guys.
joining us. Thank you,
Right, right.
everybody. All right.
Guys, bye.
Bye.